So next topic we'll go for is we have seen respirometry or spirometry, how it is performed, and what are various important definitions or information about various capacities and volumes. And we have seen that very important are FVC, that is force vital capacity, and FE1, that is force expiratory volume in the first second. So on that basis many calculations are done. Apart from that, what are there, because as such if we'll see there are very little differences between COPD and asthma. So it is very important to diagnose it clearly so that we can go for treatment of it. So in that, let us see what are our objectives here, to see that what are various symptoms and evaluation which give consideration of COPDs as a diagnosis. Then check the modifiable and non-modifiable risk factors, understand the diagnostic criteria for COPDs, describe various diseases they are simultaneously present, and then what we can do. So these are very important things which we are going to have a differential diagnosis, like evaluation of the patient, check the risk factors, and check various diagnostic criteria and what are other conditions which are important. Now evaluation, what we are going to do, so we assess various symptoms like severity of breathlessness, how severe the breathlessness is there, whether cough is there simultaneously, again cough is how much time, what is the severity of it, whether sputum is produced or not, if yes, then what type of sputum, is there any wheezing kind of sound is going on, is there any chest tightness, and whether there is a weight loss or anorexia along with this. Then next is, these are various evaluation parameters are there. What are others? We'll go for checking medical history, like whether there are any allergies, sinus problem, whether there is any risk factors are there, any exposures are there, like occupational environment are there, is there any family history, whether there are any comorbidities that may affect the activities, what medications are going on, and what are the situation prior hospitalization, and what are the evaluations so far done so that we can get the detailed history of the patient. That will help in understanding in better way. What are various vital signs like respiratory rate, how is the pattern, whether it takes effort or not, check type of respiration, whether it is a sternocleidomastoid type of their arm brace on knees and table, check whether the person can speak, whether there is any difficulty in speaking a full sentence, then see the lips, what is the nasal flaring, whether it is abdominal type of breathing or not, whether the patient is sweating, check it out, get pulse oximetry nowadays what is the partial oxygen pressure, these are the important one. Check extremities for cyanosis, blueness in color, if there is a decrease in the oxygen or blood supply to that area. Go for chest inspection, check the barrel chest disease, that is whether what is the diameter of the chest area is there. Check the palpitation and percussion of the chest. These are other ways has to be done. Check the lungs, auscultation for wheezing. Sounds are there, wheezing type of sound, crackles and decreased breath sound. So these are all sounds that they should be checked. Then what are the various differential diagnoses should be considered for patient who present with following symptoms. So chronic coughs, sputum production, then dyspnea, increased sputum production, and all of the above. So for COPD you need all of the above, A, B, C, D, all four should be there, and then you can think about differential diagnosis. so that whether it is COPD, whether it is bronchitis, whether it is asthma, you can be having a very clear. Particularly, this none of these symptoms alone is a diagnostic. So if it is singularly present, it is not giving diagnostic. Then it should be then included in the differential. Differential means we are trying to differentiate between different type of obstructive OLD, we call them, that is obstructive lung diseases. So there are various kind of obstructive lung diseases like asthma, like COPD, like bronchitis, etc. So out of what exactly it is there, so we can go for that. The patient who smoke, who are over 40 years of age and have more than one of these clinical indicators of chronic lung diseases, they are more likely to have COPD. Okay. By suspecting COPD in patient with undifferentiated symptoms, the diagnosis may be made at an earlier stage of the disease when the intervention are likely to help. Then next is, what are differential diagnosis we have to go for. So we have to categorize whether the patient is having this breathing problem, whether they are because of the pulmonary causes or non-pulmonary causes. So breathing problem means apnea, difficulty in working, difficulty in exercise, all. So non-pulmonary, there can be many reasons. It can be CCF, that is congestive heart failure. It can be hyperventilation syndrome or panic attacks. It can be because of focal cord dysfunction. It can be because of the obstructive sleep apnea, which is not diagnosed. It can be because of infection, that is of aspergillosis. It can be a chronic fatigue syndrome. So the person gets fatigue early and therefore cannot exercise or cannot do physical activity. But they have no problem in all these patients. There is no problem in lung. The patient who are having problem in lung, you don't know sputum, Rucha?
No, sir.
Okay. Sputum is, have you ever had cough?
Yes, sir.
So when your cough is there, along with the mucus secretion is there. Hello?
Okay. Okay, sir.
Thick mucus secretion is there, which you expel it out, you throw it out. And actually we have discussed it during pharmacology, if you remember, cough, dry cough and wet cough. Dry cough means without sputum production, and wet cough means more sputum was there. Okay, no problem. Is clear?
Yes, sir.
Okay. So these were all non-pulmonary reasons. Then asthma, for pulmonary there can be many other reasons. Example, asthma is very prominent, which is in most of the people. Apart from that, it can be bronchogenic carcinoma, that is cancers related to bronchi or nearby tissues. Then bronchiectasis is again one of the problem where there is a rate of respiration or there is obstruction is there. Tuberculosis is an infection of lungs or pulmonary infection. Because of that, the oxygen transfer activities are reduced and the lungs are affected. Because of that, secretions are there. Cystic fibrosis is a disease again which is related to lungs and the muscles nearby. Then interstitial lung disease, then bronchiolitis obliterans. This is again having sort of anatomical problem which is causing obliterans usually, that means wrong connections are made. Then alpha-1 antitrypsin deficiency, this is important for the coiling, recoiling and activities. Pleural effusion, pleura you know, which is outer covering, there is a pleural secretion is there and that is effused out, that is causing a problem. Pulmonary edema is one of the problem. Recurrent aspirations, aspiration means something goes to the respiratory tract which should have gone for particularly if you remember, we have seen organophosphorus compound poisoning earlier. We have seen that because of that secretions are there, and this secretion can go into respiratory tract. So this secretion or any food atom or any drinking atom, instead of going to the digestive system, it goes to respiratory system, then we call it as aspirations. Then tracheobronchomalacia, then recurrent pulmonary emboli, that is thrombus formation or obstruction into pulmonary arteries. Any foreign body is there which has causes occlusion. So these are so many reasons which are there, and before that the reason has to be finalized, that what can be the reason, whether it is asthma, whether it is any other kind of COPD or any such things, it has to be there. Asthma is the most common alternative diagnosis that mimics COPD, that is asthma. Others can mimic COPD due to overlap in the symptoms and physical findings. So other can also cause overlapping in COPDs. By taking into account the clinical characteristics and epidemiological factors, the differentiation may be narrowed down. So we can check, example, tuberculosis is also causing problems, COPD is also causing respiratory problem, asthma is also causing respiratory problem. So how to diagnose? Then we can understand that when if we check, we go for various tests, including antigen test or the microscopical test, we can find the tuberculosis microorganism. Then we can say that that particular condition is tuberculosis. So like that, go for various clinical characteristics, epidemiological factors apply, and then differentiation can be narrowed down. Differential diagnosis is derived from symptom complex in the history and the physical examination, and further evaluation is with specific study like chest X-ray and spirometry will help into confirmation of the diagnosis. So these are how we can go for final diagnosis with one by one. So example, we ask a question ourselves during diagnosis: which of the following is the most appropriate to use confirm the diagnosis of COPD? So whether chest X-ray, arterial blood gas, spirometry, high resolution CT scan of chest, clinical examination. So most important is a spirometry, that gives very good differentiation with other. We shall see about it. Okay. It is a gold standard for diagnosis of COPD. It is the standard to establish severity or stage-based FE1 and FE1 by FVC ratios. It should be performed in both pre and post bronchodilator, since airflow limitation, that is not fully reversible, and that is the hallmark of a disease. But if it is reversible, then it can be asthma. This is very, very clear diagnosis. And if there is no big change after bronchodilator addition, then it can be COPD. So this is first type of. Just a minute. हाँ शेख बोलो, इस्माइल बोलो. So these are very, very important. The first criteria we have seen, that is first differential diagnosis. We are going for spirometry. During spirometry we determine FEV1, FVC, we take the ratio, and after taking ratio, go for, in all cases in this patient, give bronchodilator. If there is an improvement in the ratio, if there is increase in the FE1, then it is a bronchial asthma, and if there is no big change, then it is a COPD. So all this important thing is, all international practice guidelines use spirometry in the diagnostic criteria for COPD. Chest X-ray can also help in ruling out other causes of chronic lung diseases, and blood gases may help to establish if the supplemental oxygen is required. Because if the oximetry shows that there is a less oxygen in the body, then we need to supply oxygen. High resolution CT scan may help in severe cases to exclude the malignancy and other causes. So although everything is there, but how to differentiate between COPD and asthma. So this spirometry is the best way of doing it. So study that may help in diagnosis. These are chest X-ray, spirometry, arterial blood gas, alpha 1 antitrypsin level, then high resolution CAT scan, and these are all having strength of recommendation as a C. If we remember earlier our classes, that is whatever the class of recommendation or COR or strength of recommendation. So why chest X-ray we are doing? It is helpful in excluding alternative diagnosis. Seldom diagnostic, but may having hyperinflation, bullous changes, decreased vascularity, normal with results with chronic cough can occur with COPD, asthma, postnasal drip. Then spirometry we are doing, we need to confirm the diagnosis, whether it is COPD or asthma. I have told you FE1 by FVC ratio, that helps. These arterial blood gases, they are helpful if the PO2 is less than 60. It can help to determine whether we need to supply oxygen. Then alpha 1 antitrypsin level with severe alpha 1 antitrypsin deficiency usually are of European people, that is European by race, and they develop clinical evidence of COPD approximately 10 years earlier than the patient who are not alpha 1 antitrypsin deficient. So this is again important, patient who are having severe alpha 1 antitrypsin deficiency. So they are of European, and in that they develop the clinical evidence of COPD after 10 years earlier than the patient who are not alpha 1 antitrypsin deficient. So these people are having more chances of COPD. Okay. So these are various signs, symptoms which we have seen, and then high resolution CAT can give this CAT scan will give whether the diagnosis is unclear. It will help to detect any tumors or any cancer like situation. So thus we are using, these are the reason how all these are helping. So we have seen that spirometry is the gold standard for diagnosis, particularly differential diagnosis, standard to establish severity and the stage of that disease. It can perform both pre and post bronchodilator, and we call it as a irreversible airflow limitation. That is airflow limitation, that means less or decrease in the FE1 by FVC ratio. If it is less, then we call that there is a limitation in the airflow. So that can be reversed with the bronchodilator in case of asthma. But if it is irreversible, it is the hallmark of COPD. Okay, this is very clear guidelines. So what we are doing is we are performing pre and post bronchodilator, this one, and airflow limitation is that which is not fully reversible, that is a COPD. In severe persistent asthma, airflow limitation may not be fully reversible, but most other diagnoses will inform about characteristic whether it is asthma or not. There are every chance that it is mix of asthma and COPD, and in that condition we have to consider it in that way. All the patients should be evaluated for spirometry to establish the diagnosis as per the international guidelines. Without spirometry, it is very difficult to distinguish older adults with asthma from those which are COPD. The home lung function tests are marked on the internet, but they are not established to make the diagnosis of COPD, but they are useful in the monitoring asthma conditions. So these are various conditions whatsoever one can do at home. They are not very accurate, and okay, they can just say that asthma is improving or there are betterment in the asthma, but they are not useful in the COPD. What are risk factors for COPD? Smoking is the major risk factor. The risk increases with number of years smoked, that is number of packs and number of years one person is smoking. Second hand smoke in the large amount present, the second hand means simultaneously sharing it, it presents the risk. Then the places where there is a more environmental pollution like smog, then exhaust from vehicles, smoke from burning wood or other biomass fuels, particulate in the occupational dust. So in that cases there are more chances of having COPDs. The most significant risk factor is long-term cigarette smoking, but it is very important. The more years the person smoke and more number of cigarette person smoke, the more are the chances to have COPD. The smokers are who are susceptible for lung injury experience and an increase in the rate of age related loss in FE1 compared to non-smoker. After all lung function declines to the threshold level, clinical symptoms develop, and when the smoker stops smoking, the rate of FE1 loss again approximates to that of non-smoker. So this is how smoking is affecting, smoking is dangerous, and that result into COPD. Symptoms of COPD usually appear about 10 years after smoking starts. Pipe smokers, cigar smoker, and people who are exposed to large amount of secondhand smoke are also at risk. Environmental, we call it as a passive smoking also, that is those which are, suppose someone is staying in the nearby of the person who is smoking, or it is a closed room where people are smoking, and maybe there are other who are not smoking and they never smoke, but we call it as a passive smoking because they also get these all gases inhaled. Environmental pollution like smog, dust, they are affecting the person, and they can also contribute into it. Apart from that, various occupational irritants are there. Example, person may have occupation in as an agriculture worker, coal miner, concrete worker, construction worker, gold miner, hard rock miner, rubber worker. In all these cases, fume are there, or some dust is going on, or in agriculture some other particles are there. So this can go and they can cause obstruction. Then the person who are working in various situation like having irritant endotoxin or coal dust is there, mineral dust is there, dust of any kind including silica, example marble mines or marble cutting places, mineral dust is there, industrial chemicals are there. So these people are at very high risk because these particles will go through their respiration and will be affecting these people. Then other risk factors are non-modifiable risk factors like gender, which are attributed to smoking habits of both gender. The risk is almost equal in men and women. Those who are smoking more, they have more chances. Age, COPD develops slowly. Most people which are having age more than 40 years of the old age, and then the symptoms will start. Then alpha-1 antitrypsin deficiency is important. Like northern European people, they are hereditary, have this problem. Rare cause of this, that is only 2% of the COPD population have this reason, that is they are having genetically alpha-1 antitrypsin deficiency. So these are various. Then let us go for diagnostic criteria. So there is one big organization which is working for obstructive lung diseases, and they have given a global initiative for whole world. They have given some guidelines, some ideas. They are called as a gold criteria. G for global initiatives, and the next are OLD, that is obstructive lung diseases. So these are the global initiative for chronic obstructive lung diseases. They are called as a gold criteria or gold guidelines. This is the program to provide guidelines for the management of COPD. It was started in 1998. It is an international effort, and they are working for COPDs. They are working for various conditions which are affecting pulmonary function. They consider COPD in any patient with following: if there is a dyspnea, if there is a chronic cough and sputum production, and or there is a exposure to the risk factors. So these are the various conditions which shows. Then next is symptoms and the risk factor which are not diagnostic in themselves but should be prompt spirometry in patient above age of 40 years age. Diagnosis should be confirmed by pre and post bronchodilator spirometry. So these are various conditions. This has to be checked, and accordingly one can go for spirometry. Let us see the next. That is what are key indicators. Again, dyspnea. That is dyspnea, you must be knowing, that is difficulty in breathing or abnormal breathing. It is a progressive, usually worse with the exercise. There is a persistent, describe an increased effort to breathe. So breathing becomes difficult, so person has to, we call it as sans chadagi or hapna. So this is what is a dyspnea. Then chronic cough. It may be intermittent, it may be productive or non-productive. What do you mean by productive cough? The productive cough means which is producing sputum simultaneously is a productive cough. Non-productive cough means which is not producing sputum is a non. There can be any pattern of sputum production. Then history of exposure to risk factors. Just a minute. So how this is working, that we can see. Then these are all various, we shall check whether there is any history of exposure to the risk factors like tobacco, smoke, occupational dust. I told you mining industry, any kind of mines. There are some people working on various chemical industry where fumes are there, or smoke or there, smoke from cooking or heating of the fuel is there, or agriculture people are there. So in all cases it can be there. We can have various indicators for diagnosis. It can be symptoms, clinical findings, or historical risk factors. We can check the dyspnea, whether dyspnea is progressive, it is worsening with the time, more and more difficulty one is getting. Then whether there is increase in this with the exercise, this dyspnea is more. Now similar dyspnea is there in cardiovascular disease also. Therefore we have seen that these are the factors which are non-pulmonary. Then persistent, even which is present every day, described by patient as increased effort to breathe or heaviness or air hunger or gasping. So is finding very difficult to complete the quota of oxygen or air. Therefore having very deep and heavy breathing rate is increased. It may be intermittent and unproductive or productive cough can be there. Chronic sputum production can be there. Any pattern of the chronic sputum can be there. And various risk factors, as we have seen, that is tobacco smoke, etc., can be there. So these are all risk factors we should be knowing about it. Then, as I told you, very, very important is the ratio. FE1 by FEC ratio. If it is less than 0.7, that is, if it is less than 70%, then we can say that yes, it has got a chance of COPD. And on the basis of FE1, we can have further categories. Mild is having where your FEV is almost greater than 80% of the predicted value. Predicted value means which are the normal values of various person, and during the normal respiratory rate. So if it is 80% is there, then we can say that it is mild. If it is 50% to 79% of the predicted value, we can say that it is moderate. If it is 30% to 49% of the predicted value, we can say that it is severe. And if it is less than 30% of the predicted value or less than 50% of the predicted value with chronic respiratory failure, then we can say that it is very severe or dangerous. And this is how it is helping us, how it is giving guidelines. Now we will go for, we already seen that what are various comorbid or what can be the situations for the respiratory problem. So we have categorized them in the pulmonary and non-pulmonary situations. So there are conditions which are having uh, symptoms which are very similar to COPD, and that can cause confusion in the person, in the particularly in the clinician. So those which are bold, which they are having almost similar signs, and they can cause confusion that whether it is COPD or it is that disease. So this is example of this which can cause the confusion, or which can have similar action, similar diagnostic features. These are asthma, bronchiectasis, tuberculosis, cystic fibrosis, then bronchiolitis obliterans, then tracheobronchomalacia. These are the pulmonary situations, and other are cardiac, like congestive cardiac failure. They will cause similar signs like dyspnea, difficulty in breathing, exercise related problem, decrease in the oxygen pressure. So these are there. Then you have to differentiate whether it is chronic heart disease, or whether it is asthma, whether it is COPD. That we have to confirm, and accordingly we can go for various tests. So most problematic is differentiated with asthma. Other we can have CCF, we can have other measures, like we can go for echocardiography, we can go for the ejection fraction variation checking. So we can get easily that it is, or we can check with the ECG or such other tools, and that will clearly give us that it can be because of the heart failure. The biggest problem is happening when one has to differentiate between asthma and COPD. Many other illnesses, they share symptoms and physical findings with the COPD. Most can be excluded without extensive workup, but some will require the judicious utilization of various tests, particularly those which are having very similarity in the signs, symptoms, and therefore we have to go for differential diagnosis, which is derived from the symptom complex which are obtained from the history, finding of the physical examination, and the result of specific testing like spirometry. On all these results we have to check, and then we can go for the final decisions. So let us check what are various diagnostic criteria are there. If we have to compare it with the asthma, what we'll do? We'll check episodic symptoms of the airflow obstruction or airway hyperresponsiveness. Airflow obstruction partially reversible by spirometry, characterized by reversibility and variability in the symptoms and the airflow. Alternative diagnosis excluded by the history and examination. These are the major things which are there with the asthma. So it is the primary diagnosis must be distinguished or must be separated from the COPD. So COPD will, how we can do it? First is check whether it is episodic syndrome of the airflow obstruction, or there is a airway hyperresponsiveness. So that is more chances of asthma, because it is episodic, it is not continuous, it is not always. However, the person who have got because of smoking, this COPD is there, example emphysema is there, then in that cases it is almost it is almost there. So it is not episodic, it is continuous phenomena. Airflow obstruction is at least partially reversible during spirometry. How it is reversible? If we give any bronchodilator agent, then there will be bronchodilation, and because of that there will be improvement in the spirometry. This is there with the asthma. It may not be possible with the emphysema or COPDs. So this is another criteria, this is another way by which we can have this diagnostic. Then it is characterized by reversibility and the variability of the symptoms and the airflow. We have different kind of airflow variations. Alternative diagnosis, they are excluded from the history and examination. So on that basis, this we can understand, then we can change it, we can compare. What are the similarity between asthma and COPD? More epidemiologic causes of chronic obstructive airway disease. So whenever there is a chronic obstructive lung disease or respiratory disease, then it can be either asthma, it can be COPD, or it can be common, it can be a mix of both. Most involve underlying airway inflammation. It causes airway inflammation, underway, whatsoever it is there. Okay, that is the reason behind this. It can cause similar chronic respiratory symptoms and fixed airflow limitation. So the symptoms are chronic, it is lasting long, it is lasting almost lifetime in the patient of asthma, and they have got limitations of airflow, so that limitation remains there. It can coexist with the other, making diagnosis more difficult, so it can coexist with the other diseases. Example, if it is existing along with CCF, congestive cardiac failure, then it will be very difficult for diagnosis exactly what is a problem, or simultaneously it is having similar to that of emphysema or COPD, then it will also show same signs, symptoms and similar activities. So asthma, that is similarity of COPDs are emphasized. Two can coexist, means both can be there in a person. It can COPD also and it can be asthma also, and if it is there, then simultaneously we need treatment for both. COPD and asthma both are major epidemiologic cause of chronic obstructive lung diseases or airway diseases. Both involve underlying airway inflammation, so inflammation is important. But in case of this asthma, whenever there are some triggers are there, then only it will occur. Usually it does not remain constant like that, but emphysema can remain constant. Both can coexist with each other, making diagnostic more difficult and treatment also more difficult. So these are the situations, these are the conditions. So what are the diagnostic criteria? Spirometry, we can use both post bronchodilator FEV1 is less than 80% than that of predicted values, together with FEV1 by FVC ratio is less than 70. It confirms that airway limitation is not fully reversible. But asthma may show similar changes in the chronic and more severe cases, otherwise it is reversible. Plasma function test may be needed to distinguish it from the COPD, so go for various plasma function tests, pulmonary function tests, and then go for check it and then distinguish from the COPDs. So what we can do is, we will have this differentiation with asthma and this, go for bronchodilator treatment during spirometry, and there is a reduction in the 80% predicted together with FEV1 by FVC 0.70. It confirms the airflow limitation that is not fully reversible. Asthma may show similar changes in the chronic and more severe cases, and therefore complete pulmonary function test should be there to actually distinguish from the COPDs. So let us see what are various situations, how we can have differentiation, various features we can have, clinical features. COPD usually it is older than 35 years of the age. Asthma can be at any age, it can be there. If there is a cough which is persistent and productive cough, then we can say that the chances of COPD are more, while in asthma it is usually intermittent and non-productive cough is there, or there is no cough is there. Then smoking is important risk factor which causes a typical type of COPD. Asthma we cannot say, it may have impact on the smoking. Dyspnea is there, which is progressive and it is persistent, it go on, it continues, it does not come down. But here it can be variable. Sometimes it is, when some trigger is there, it can be too much, then after some time when the allergic or when that immune response is over, then it can try to regain its own condition. So this is how we call dyspnea can become, or it is whether it can be persistent or whether it can be variable. Then nocturnal symptoms, breathlessness late in the disease are there, while because of the coughing and wheezing, here the person may have nocturnal symptoms. So these are what various differential conditions. Again, other things are there. Family histories, how it is there. COPD, there is a less impact of the previous family background, or it is less hereditary. It is more because of the smoking and other such factors. While asthma can be genetically, or it can be dependent on hereditary, and therefore family history is important to diagnose it or to make it final version. Then atopy is there, that is less common in COPD while it is more common in asthma. Diurnal symptoms are less common in COPD, which are more common in asthma. Spirometry, that is irreversible airway limitation is there, while in asthma it is a reversible. That is, reversible means, why reversible? When we give any bronchodilator, it becomes reversible, which is possible in asthma and it is not possible in the COPD. Then next, if we have got simultaneously, or any patient have got heart failure, then some similar diagnostic feature will be there, but we can differentiate. So characteristic midlife to late life onset, that is, it is occurring quite less, is another thing, which is almost similar to that of COPD, but this is associated with risk factor like hypertension and coronary artery disease. Here in COPD we do not need. In COPD major risk factor is smoking, or any kind of smoke or mine working like thing. Clinical presentation, this shows fatigue, exertional and paroxysmal nocturnal dyspnea, and peripheral edema. There are some crackles and on the auscultations. Pulmonary auscultations, pulmonary function tests are there. They are decreased. There is a decrease in the DLCO, that is differential lung capacities are there. So that will be decrease in, it can be observed as a decrease in that, which is predominantly used to exclude other diagnoses. So DLCO is another important test which is done. We shall see about this also later. There is increased heart size in heart failure. There is a pulmonary vesicular congestion. There can be chances of pleural effusions. So this can be seen, it can be obtained from the heart X-rays or heart radiographies. Other testing which are recommended are echocardiography, levels of BNP, that is blood natriuretic peptide levels we are measuring, then ECG, then cardiac catheterization is inserted as tissues and cells. So this is how it helps, this is how it guides in various diagnostic criteria. हाँ बोल, हाँ कैस नहीं, हाँ हाँ कहीं नहीं, कहीं नहीं कहीं पैक एकदम टोटल खाली 900 समथिंग है बस 900 रुपीज़ पेज पे So these are various conditions and how we can, I told you again earlier also, for heart failure we can have echo, ECG, etc. that can help. Then another condition is bronchoectasis, how we can check it, how we can compare it. So in bronchoectasis there are midlife onset, that is again age of 40-50. Same is there with COPD, it is also having midlife. This is progressive with exacerbations, so it progresses. Clinically there is a productive cough with large volume of thick purulent sputum, that is it is very thick and purulent means having smell. There is a dyspnea. Then there is a wheezing which is associated with the bacterial infections. Therefore the sputum is having smell. Crackles are there and we can club it with the examination. We can go for pulmonary function test We can check the obstructive airflow limitations, fixed and reversible. So these are how we can confirm, we can try towards the diagnosis of bronchoectasis, which is similar to that of COPD. Tuberculosis, already I told you that we go for X-rays, we go for bacterial testing, and accordingly we get under, there is a blood present, we call it as hemolysis. Fever and the weight loss, these are very, very important signs. Hemolysis means presence of blood in sputum is called as a hemolysis. Fever and weight loss, these are various signs. We can go for antigen testing, we can go for X-rays, we can go for other testing or sputum microbiological testing, and then we can get idea what kind of problem it is. So I told you chest radiography, then sputum antibodies, sputum culture. So these are various differential diagnoses, and then we can say that yes, it is a tuberculosis, it is not there. Then bronchiolitis obliterans, which is common, then we can check it about it. It can occur at any age, but it is normally occur at younger age. So only this is having chances as asthma, which is also at younger age. In other cases, they are after 40, 50 age. Then check the history of flu-like illness, collagen vascular disease, or toxic fumes in exposure. They can be non-smoker also. Clinical presentation, often subacute presentation with dyspnea, cough and fever. We have to go for various pulmonary function tests. That is, there is a decrease in the vital capacity, decrease in the DLCO, and there is a no obstructive component is there. Only lung capacities are reduced because the space which is required to keep the air in, that is reduced. So for that we go for chest X-rays, multifocal, bilateral, or it can go for the ESR studies, that is erythrocyte sedimentation rate. High resolution CT will show the hypodense areas. Lung biopsy can be checked, and then we can determine what it can be the reason. Then tracheobronchomalacia, again we can go for important diagnostic tools like CT and other testing like flexible bronchoscopy, endobronchial ultrasonography, and then we can understand about what can be the reason it can be. Cystic fibrosis is another disease which causes decrease in the lung function and which can have similarity with the COPD. So it can be early life onset, it is a progressive with exacerbation associated with the pancreatic diseases. Failure to thrive, there are intestinal obstruction also, cirrhosis and steatorrhea. Steatorrhea means fat like material is secreted in the feces, we call it as steatorrhea. Then clinical presentation, it shows predictive cough with purulent symptoms, sputum. There is a dyspnea and wheezing, predominantly fixed airflow obstruction will be there. Then other diagnostic criteria for cystic fibrosis, it shows bronchoectasis, frequent in the upper lobes. Then sweet chloride test is there. So check, then go for bacterial sputum culture. So these are various tests which we can check out, we can rule out with the COPD, and this is how we confirm what is, whether COPD is there, asthma is there, or other pulmonary or non-pulmonary problem is there, and accordingly we can plan for the treatment. So we have finished. One of the important is how we can diagnose, then we will go for treatment in our next class. So I hope the things are clear to you. If you have difficulty, you can